Okay, this is going to be shock part 2, and this is going to be the stages of shock. First thing I want to talk about here is compensatory shock or compensated shock. The body has the ability to detect an increase or to detect a decrease in cardiac output. I'll get it right here in a second. It does this through baroreceptors and chemoreceptors located throughout the body. How these work. Baroreceptors work off of pressure. You have them in the heart and in the major vessels, aortic arch, carotids, and areas like that. So let's go through this. And these things generally run like a figure 8 whenever we're looking at these charts. So homeostasis, blood pressure rises above the normal range. The baroreceptors are stimulated because they feel the pressure. They're a receptive area in the vessels. The cardiac acceleratory center is inhibited, so please do not turn on the gas. The cardiac inhibitory center is stimulated, so we get a vagal response. We get a decrease in cardiac output. Vasomotor center is inhibited, so we get vasodilation occurring, and hopefully the blood pressure reduces and homeostasis is restored. On the other side of it, blood pressure falls below a normal range. We get a reflexive response from the baroreceptors again. Vasomotor centers are stimulated, and this causes vasoconstriction. Cardiac inhibitor center is inhibited. So we don't want to put the brakes on. We actually want to kick the brakes off. The cardiac acceleratory center is stimulated, which this increases cardiac output. Blood pressure raises, and hopefully homeostasis is restored. Again, kind of looks like a figure 8. Chemoreceptor reflex. This one doesn't have a lower half, so it's going to kind of look like a circle. Starts off with homeostasis. A decrease in the amount of O2 or the pH. This guy is becoming more acidic. Elevated CO2. So they're retaining CO2 or their cellular metabolism. They don't have enough oxygen going to it. And this would be in the blood and the cerebrospinal fluid. Chemoreceptors are stimulated. Cardiac acceleratory center is stimulated. Let's give them some gas. Cardiac inhibitory center is inhibited. We want to take off the brakes. Vasomotor center is stimulated. Vasoconstriction occurs. Respiratory centers are stimulated because of these right here. Respiratory rate increases, so hopefully we have just put enough resources in play to where homeostasis is restored. Compensated shock continued here. The body has the ability to compensate for a decrease in cardiac output. Compensatory mechanisms are activated. An increase in peripheral vascular vasoconstriction. The vessels get smaller. Heart rate increases. Increased myocardial contractility. And an increase in peripheral vasoconstriction or peripheral vascular resistance. All three of these things are increased. Maintenance of blood pressure. If the insult is not recognized and corrected, will proceed to progressive stages of shock or decompensated shock. Progressive shock. Anaerobic metabolism. So in this, we're only making 2 ATPs. We can easily go into cellular bankruptcy. We get tissue hypoxia. Additional compensatory mechanisms are activated. Water retention in the kidneys, profound vasoconstriction, an increase in heart rate, which also increases oxygen demand. Increased myocardial contractility, also an increase in oxygen demand. Decompensated shock, we get cellular death. Can occur suddenly or over days. If we cannot get ahead of the physiology that's in play, then the patient will die. The prognosis for decompensated shock is poor. General management of shock. Correct the underlying problem. Provide supportive care while attempting to identify the insult. Airway, ensure the patency. Breathing, adequate ventilation and oxygenation should be maintained. Circulation, ensure adequate tissue perfusion. Volume resuscitation and vasoactive medications if required. Correct their acid-base abnormalities. This goes back to something we learned in the airway management of the Bohr effect. How does the red blood cells know to offload their oxygen? And the answer is changes in pH. So if you have a systemic change in pH, very simply, you're going to offload as soon as you hit the blood and conserve body temperature. Initial assessment and management. Same as other critically ill patient, the goal is to identify and treat any potentially life-threatening injuries. Airway, first priority, assess immediately, control with a chin lift, a jaw thrust, insert a BLS airway, OPA or nasopharyngeal airway, oropharyngeal airway or nasopharyngeal airway, and endotracheal intubation as indicated. Assure cervical spine stabilization when warranted. Breathing and ventilation when performing an assessment. Verify the presence of bilateral breath sounds on auscultation. Assess the rate and depth of respirations. Expose the chest and inspect for signs of trauma, anterior, lateral, and posterior. Management. Administer 100% oxygen via appropriate method. Assess ventilatory status with capnography. Again, if the end-tidal CO2 is rising, they are offloading a tremendous amount of CO2. Please adjust your oxygen input. Circulation. Assessment of circulation, blood pressure, pulse rate and quality, skin color, temperature, and capillary refill time. Management, BLS maneuvers, raise their legs, ALS maneuvers, IV cannulation, fluid administration. Vasopressors can be used. Please use the vasopressor for the right underlying etiologies, and we'll talk about those here in just a second. Dopamine is a generic vasopressor. Probably should start with this one. Dobutamine. These individuals have normal tension, normal blood pressure with pulmonary edema. This medicine right here increases contractile force strength and has little effect on the heart rate. Epinephrine, high beta response and a little bit of alpha, works great for anaphylaxis because it opens up our lungs and it gives us an alpha response in one medication. Norepinephrine is primarily an alpha drug. Disability neurological deficit. Assessment. Alert, verbal, pain, painful or unresponsive. Glasgow Coma Scale. Level of consciousness. Motor sensation. If altered, rule out trauma or any type of substance abuse. Examine and expose. Remove all the clothing to fully expose the patient, especially in trauma. Cover with blankets to preserve the heat once the exam is complete. Detailed exam history. Reevaluation of the initial assessment followed by a complete head-to-toe exam. Necessary to ensure that all acute and chronic insults, diseases is identified and considered. Allows for trend identification that you reassess frequently. Review of studies, imaging and laboratory, if you have them available. Patient history. Understand the circumstances surrounding the illness or injury. Mechanism of injury. History of present illness. Mechanism of injury would be primarily in trauma. History of present illness would guide you and lead you if you have a medical. Medical history is important to identify comorbidities. If you had a pre-existing disease, if it looks like a duck, walks like a duck, and talks like a duck, it generally is a duck. Medications, alcohol, illicit drug use, any type of allergies, tetanus immunization history, and then allergies, medication, past medical histories, last oral intake, and everything that led them to what is currently happening, or an ample history. Head-to-toe exam should be conducted pretty much in this order. Head, face, neck, cervical spine, chest, anterior, lateral, and posterior. The abdomen, peritoneum and genitalia, back and spine, extremities, vascular, and then neurological. Management and further evaluation. Management is the same for any critically injured patient. An ABCDE method for prioritizing the management of life threats. Specific management for shock can occur after management of potential life threats. Management of potential life threats may help manage the shock as well. Example, if you have somebody bleeding out and you stop the bleeding process, most of the interventions that you've already brought to bear will work probably better. General treatment considerations. Airway management and ventilation is key. Begin aggressive airway management early, endotracheal intubation when necessary, the use of neuromuscular blocking agents when necessary, confirm the placement with end-tidal CO2 detection and end-tidal CO2 monitoring. Mechanical ventilation. Must be familiar with the patient's needs and available vent settings. Fluid resuscitation. IV access. Peripheral IV access, 2 large bore IV lines. Central venous cannulation if peripheral IV access cannot be obtained. Administration of large volumes of fluid are anticipated, or hemodynamic monitoring is required. Goal is to achieve no more than 75% of the pre-injury blood pressure. We allow permissive hypotension. This prevents excessive bleeding, loss of coagulation factors, 200 ml fluid boluses, and reevaluate and repeat as needed. 75% of their normal blood pressure. Hemoglobin-based oxygen-carrying solutions, or HBOCs. Major development in emergency and critical care medicine. They differ from traditional IV volume expanders. They can transport oxygen, contain polymerized hemoglobin, obtained from human or bovine blood, removed from red blood cells and is isolated, no infectious agents, antigenic proteins, or other blood constituents. Hemoglobin molecules joined in the large change and polymerization occurs. Is compatible with all blood types, does not require typing, testing, or cross-matching. First one we're going to talk about here is polyhem, derived from expired donated human blood, contains 50 grams of hemoglobin per unit, same as human blood, must be refrigerated, and has a 1-year shelf life. Hemopure is derived from bovine blood, does not require refrigeration, and has a 3-year shelf life. Volume expanders. Hypertonic saline showed potential initially, but recent evidence suggests it's no more effective than a standard isotonic crystalloid. Colloids, popular outside the United States and Australia, no more or less effective than crystalloids. Crystalloids are going to be normal saline and lactate ringers. Blood and blood products. O negative is used if time for typing and cross-matching does not exist. Type and cross-match blood products are preferred. Whole blood versus packed red blood cells is also preferred. Pharmacological agents. For shock unresponsive to fluid boluses, administer the following. And again, quick overview. Dopamine is a generic type of vasopressor. Dopamine does everything. It increases heart rate, contractile force strength, and at higher doses, peripheral vascular resistance. Dobutamine. Dobutamine is utilized for the normal intensive patient. That is experiencing pulmonary edema. Dosing for both of these are 2 to 20 mics per kilogram per minute. Epinephrine. Epinephrine is utilized primarily whenever someone may have overdosed with a beta blocker, or you need a big beta response. We use it in anaphylaxis, asthma, cardiac arrest, bradycardias in drip form. So epinephrine is utilized either in drip form or boluses for multiple areas. Norepinephrine. This is a distributive shock med. and it gives us an alpha 1 response. If we have sepsis, neurogenic shock, or anaphylaxis, and I'm not talking about the kind that's responding to the epinephrine, I'm talking about the anaphylaxis that doesn't respond to normal therapies, we can get containment back with norepinephrine. Start off slow and increase in increments. Do not open up the medication wide and allow it to flow. In sepsis, it would control the widening out, or it would apply some vasoconstriction to the actual vessels. In neurogenic shock, you have a spinal cord sever that's high. You have a loss of sympathetic tone. Vessels dilate out. Upper half that's under sympathetic tone will be cool clamming diaphoretic. Lower half will be dilated out. Anaphylaxis with the loss of containment from a histamine response. Again, all of this is peripheral vascular resistance, or how big your vessels are. If we understand where the actual ailment is, we can attack it directly, which would be with an alpha 1. This brings us to the end of part 2. If you have any questions, feel free to contact me, roy.smith@redlandscc.edu or smith@imsa.net. Thank you.